Hi, good morning. So, River and I have another exciting collision case to share with you.
Awesome. So, what can you tell me about the clinical history?
So, this patient is a 25-year-old male. He has a past medical history of hypertension, diabetes, chronic kidney disease, and he actually presents with nephrotic syndrome. His proteinuria was 9 gram. His creatinine was 1.25 milligram per deciliter, and he had an albumin of 1.8.
So, what do we see on light microscopy?
So on low power, we have cortex that shows tubular epithelial injury. We can see here that there's attenuation, there's thinning. We also have some vacuolization, and there's cytoplasmic swelling and also reactive appearing nuclei. When we look at the trichrome stain, we can see that there's worse interstitial fibrosis compared to the tubular atrophy, also known as a protracted pattern.
What about the glomeruli?
So here we can see that the glomeruli are actually pretty unremarkable. They don't show any mesangial expansion. There's no endocapillary hypercellularity, no fibrinoid necrosis or crescent formation. But when we look at the Jones stain, we can see that there are some segmental holes in some areas.
Interesting. Let's see if the immunofluorescence shows anything.
So here we have our immunofluorescence IgG staining. And we can see that there is strong positive reactivity here in the capillary loops, again in a segmental pattern. And we can also see it around the Bowman's capsule. This staining was similar in our C3, kappa, and lambda staining. We can also see in this image that there is a lot of staining in the IgG for tubules in a granular pattern.
Are there any stains that would help us with the differential?
So we could consider a NEL1 staining because it looks like it's a membranous pattern and it's very segmental. But we could also consider a LRP2 stain, which would further characterize the deposits, specifically as we have them in the tubules. So here we have our LRP2 stain, which should normally only stain the brush border over here. It should not be found along the tubular basement membrane. So we can see a patchy positive granular staining along the tubular basement membrane, which means that the stain is positive. So here's another picture where we can see again our control is the brush border, and then we have the tubular basement membrane staining too. And on this picture, we can also see it's highlighting the Bowman's capsule and also where the segmental capillary loops are.
So, what did the electron microscopy show?
So on electron microscopy, we can see on low power that the basement membranes are uniform and of normal thickness. We don't see any deposits along the capillary loops or within the mesangium. But on this is a higher power picture. We can see that there's diffuse widespread foot process effacement along the capillary loops. We can also see microvillus transformation.
So, with these findings, what was your final diagnosis?
So with all of these findings put together, we have two diagnoses. From the EM, we have minimal change disease. And from our LRP2 findings, we have an anti-brush border antibody disease, which is an LRP2 associated nephropathy, which goes together with the severe protracted tubular, the immunofluorescence staining of the tubular basement membranes and segmental glomerular capillary loops, and the positive LRP2 staining.
Wow, Rachel, thanks so much for sharing that case. Let's ask the audience now. Do you guys think these two diseases in this patient are separate entities or are they related?
Thank you so much for joining us.
And stay tuned for our next episode in our Kaleidoscope series.